Yeah, so we went into this study under the premise that young women are much have a much higher unmet need for contraception than older women. And this project was in collaboration with Pathfinder International and the Gates Foundation. And through decades of on the ground work, they had this strong belief that a key driver of this unmet need was bias in the clinic, that young women experience worse outcomes when they come into the clinic due to bias among providers. And so we kind of thought that this was a phenomenon that existed, but we didn't really know the details of it before we went in and studied it. And we did this through these mystery shoppers. And so the mystery shoppers, we randomized whether they were young, unmarried, or nulliparous, and kind of had the counterpart of each, so old, married, and had a child. And we randomized those and we sent them into the clinics, about 226 clinics across Burkina Faso, Tanzania, and Pakistan. And what we found is that the way that bias manifests is somewhat nuanced, and it depends on the characteristic of the client. And so we found that the women who were assigned to be young, 15 or 16 years old, they were less likely to be able to take a method. And so they thought that they wouldn't be able to take any method at all, kind of being denied a method. The women who were didn't have a child yet, they were counseled on a different range of methods. And so some methods were excluded, things like hormonal methods, because there's this common misperception that certain methods lead to worse prospects for having a child in the future. So if you hadn't had a child yet, then they kind of avoided these types of methods. So they got kind of restricted counseling. And then the unmarried women, they experienced just worse treatment from the providers. There didn't no change in counseling, no change in the likelihood of being able to take a method, but they just weren't treated very well by the providers because like this stigma against being unmarried and having sex. So that was a key finding from this study is just kind of the way that bias materializes across these different characteristics of clients. Yeah, so we designed an intervention across all three countries in collaboration with Pathfinder International and a human-centered design firm called Y Labs. And the intervention had these three components. So this first component is we called it Summit that brings all the providers together and it does these in-depth storytelling, brings clients in to talk about experience of bias. Providers talk about times when they provided bias care, and it focuses on the consequences of this bias care. And the idea here is that this is meant to change negative attitudes and beliefs that providers might have towards young clients. So that's the first component. And the second component is this peer support component where it starts immediately after this initial summit happens, and it continues for 8 to 10 weeks. And the idea here is to kind of keep the conversation going from the initial summit. And so providers can continue to talk about bias, talk about experiences they have after summit, and just kind of keep the peer bonding going. And then Pathfinder staff was also involved in this process, and they would pose questions that providers could discuss and things like that. And so the idea is to kind of keep all this new information and change beliefs that happen during Summit salient over time so it doesn't kind of wear off. And then the third component is called non-financial awards. And the idea here is that the best performing clinics, and in terms of providing the least biased care, they get recognized in this public ceremony and get this party in a box that they get to take back to the clinic. And the idea is to kind of, one, make it a social norm that this is a good thing to provide unbiased care. And then two is just to kind of keep this conversation, like motivate providers to want to do this unbiased care and just to kind of reinforce everything that they've learned from the other two components of the intervention. And so what we found is that there was a pretty big reduction in bias attitudes and beliefs in the providers that were assigned to the treatment group and they received the treatment versus those that were randomly assigned to the control group. Um, and so that's kind of good, but that's really not enough because it's totally possible that there's this reduction in biased attitudes and beliefs, but then when providers see clients, they fall back into their habits and just still provide biased care. And so we also measured the care that they provided through mystery clients and through exit surveys. So we did about 35,000 exit surveys of young clients coming out of the clinic over 12 months. And so we also found that this reduction in biased attitudes and beliefs seems to have translated into better care for young clients. So young clients received more comprehensive counseling. They were more likely to be counseled on the full range of methods. And they also experienced better treatment from the providers. So Pathfinder has actually created a how-to guide. And so that's designed for other kind of health systems, collections of clinics that want to implement this in their country or in their health system. So it is kind of designed initially for kind of a group of clinics, kind of a broad network. However, certain components of the intervention could be implemented at individual clinics. And so this summit component where getting all the providers together and talking about bias, giving examples of bias stories, bringing in some clients to give examples of when they've received bias care, that could be done at individual clinics. Um, and the peer support component could potentially be done at individual clinics, although I expect that kind of having a broader network across a lot of clinics is might be important for the effectiveness of that. So I'm not a clinician. My wife is actually a clinician who provides family planning care to people. So I'm a little hesitant to give advice to clinicians directly, but I will say that what seems to be important is just following guidelines, providing counseling on all of the potential options for a client, even if you might think one option is better than another, still expose the client to what this method, why it might be good, why it might be bad for them, rather than just omitting discussing it at all, which is what we saw happen a lot in our setting. Yeah, so I think one of the key findings that we didn't really expect going into this is that the women who experience bias or that are most likely to experience bias, the women who are really young, 15 years old, women who don't have children yet, they don't come into the clinics very often. So it was actually very rare that I think only 5% of our 70,000 surveys were women that didn't have children yet, and very few were under 18. So it just seems like part of this phenomenon of provider bias, part of what it's doing is scaring women to come into the clinics because they expect that they'll receive biased care. And so we kind of think that this is there could be broader benefits beyond the outcomes we measured at the clinic. And we think that this could lead making clinics less biased. And once the populations around these clinics know of this, we expect that that could lead to better more access to clinics among the populations that experience bias.